Hi everyone, I am Dr. Meena, Assistant Professor, Department of Physiology, Chettinad Hospital and Research Institute. And I am here to discuss the waveforms, intervals and segments of ECG. So the objectives of today's session is to understand the normal waveforms, their duration and amplitude in ECG, to understand the various intervals and segments of ECG, how to calculate heart rate from ECG, and also to know the importance of the various waveforms, intervals and segments. So before discussing the waveforms in detail, I would like to tell some basic concepts related to electrocardiogram. And we all know that electrocardiogram, it records the electrical activity of the mass of atria and the ventricular muscle cells. Essentially, the electrocardiogram, it records two basic events which are termed as depolarization and repolarization. Depolarization refers to the spread of stimulus through the heart muscle, or in other words, it is the electrical activation or stimulation of the heart. And when the stimulated heart muscle tries to come back to its resting state, we call it as repolarization. So these two terms are derived from the word polarized state. Normally, a resting cardiac cell is said to be in a polarized state, which is meant that the exterior of the cell is positive and interior of the cell is negative. This is what we call it as a resting state or a polarized state. And when the heart muscle is stimulated, what happens is there is a shift in charge across the exterior and interior of the cell. So whenever a heart is excited or activated, outside of the cell becomes negative and interior of the cell becomes positive, which we call it as depolarization. And repolarization is the return of the stimulated heart muscle to its resting state. And you have a difference in the propagation of depolarization and repolarization across the heart cells. So the wave of depolarization, it normally proceeds from the endocardium to the epicardium, whereas the wave of repolarization always proceeds from the epicardium towards the endocardium. So this slide, it gives you the recording of ECG from all the lead systems. And what you can appreciate from this ECG is, you will not have a uniform waveforms, intervals or segments in all the lead systems. So you can see here some of the wave are taller in one lead and smaller in the other lead systems. And some waves are positive in some leads and negative in other leads. Why there occurs a variation in the morphology of waveform in different lead systems? The answer to this question is the morphology of the waveform, that is whether it is positive or negative, it depends upon the orientation of the lead. So for this, you have to understand three basic principles of electrocardiogram. So we know that a lead, it has a positive pole and a negative pole. If the mean depolarization wave is directed towards the positive pole of any lead, then the recording obtained in an ECG will be a positive complex or an upward deflection. On the other hand, if the wave of depolarization spreads towards the negative pole of any lead, then the recording obtained would be a negative complex or a downward deflection. And the third principle is that if the wave of depolarization is directed at right angles to any lead, the wave obtained will be biphasic in nature. That is, it has both a positive complex and a negative complex. So these are the basic principles which you must keep in mind while interpreting the ECG. So before discussing the waveforms in detail, I would like you to know that the first thing to look at an ECG is the calibration, whether the ECG is calibrated to the standard way. So what do you mean by standard calibration is, if you are going to apply a signal of 1 millivolt, it should produce a deflection of 10 millimeter. This is a standard calibration, and modern ECG machines, they are automatically calibrated, and there are some situations where you can adjust the calibration to either twice the normal or half the normal. Say for example, in individuals with ectopic pacemakers or in patients with ventricular hypertrophy, you may not have enough paper to record the ECG in all the lead systems because the morphology of waves will be larger. So, in such cases, the standardization can be reduced to 1/2. Similarly, if you want to study the morphology of Q waves in detail, then you can increase the standardization to 2 times the normal. So, now coming to the waveforms of ECG. So, normally the waves of ECG, they are labeled as P wave, QRS complex, T wave and U wave. So, all these waves, they reflect the activity that is going in the atria and the ventricles. So, the P wave, it normally represents the depolarization of atrial myocardium. The QRS complex, it represents the depolarization of ventricular myocardium, and T wave, it represents the repolarization of ventricular myocardium. So, now one might get a question, what happens to atrial repolarization? You do not have any waves to represent atrial repolarization. Why? This is because you have atrial repolarization which is happening in the right and left atria. But these electrical activity are of low amplitude which cannot be picked up by the surface electrodes, and hence you do not have any waveforms to represent the atrial repolarization. So, this is the conducting system of the heart. So, the conduction pathways or the tract which is followed by the impulses generated from the SA node till it reaches the ventricular myocardium is depicted on the ECG. So, your P wave, the entire P wave, it signifies the activity of your atria. The QRS complex, it signifies the depolarization of ventricles, and the T wave, it represents the ventricular repolarization. So, this is the lead 2 ECG, where you have the typical waveforms which can be appreciated. So, now we will be discussing each waveform in detail, and the points which will be discussed here are the contour of the wave, how it appears in different lead systems, what is its amplitude, duration and its significance. So, now coming to the P wave. So, the reason for P wave is it is caused due to atrial depolarization. And here the important thing which we must know is the first half of the P wave is recorded by the activity of your right atrium, and the second half of the P wave is recorded by the activity of left atrium. So, your right atrial and left atrial activity summate to form the P wave, and the contour of P wave is smooth and it can be either entirely positive or entirely negative in all the lead systems. So, the duration of P wave is normally less than 0.12 seconds and the amplitude of P wave is about 0.1 to 0.12 millivolt. So, the contour of P wave, it is smooth, and this P wave remains negative in the lead AVR and it is biphasic in the lead V1. This is the important point which we must remember if you are looking at the morphology of P wave. So, remember, P wave will be negative in the lead AVR and biphasic in the lead V1. This is because the lead AVR is oriented horizontally and it is also oriented to the right of your shoulder. and the electrical activity that arises from a sinoatrial node, it spreads towards the left, and that is why you have a negative P wave in the lead AVR, whereas in lead 2 your P wave remains always positive. So, next is about your QRS complex. So, the QRS complex, it represents your ventricular depolarization, and this is the difficult complex to interpret in ECG because you may not have all the 3 waves in all the lead systems. You may have 1 or 2 waves which are absent in the QRS complex. So, the amplitude of this QRS complex should be more than or equal to 5 mm in limb leads. So, as we all know, ventricular depolarization is recorded as the QRS complex. So, this ventricular depolarization happens in 2 phases. So, the first phase happens with the septal depolarization or the interseptal depolarization, which proceeds from left towards the right. And the second phase is the depolarization of the bulk of both the ventricles, right as well as the left ventricle, but your left ventricle is electrically predominant considered with the right ventricle. So, to understand the morphology of QRS complexes, first you must understand the nomenclature of QRS complex or how the QRS complexes are named. So, the first negative deflection of a QRS complex will be labeled as Q wave, and the first positive deflection will be the R wave, and the negative deflection that follows the R wave will be labeled as S wave. So, you can see here there are some letters which are represented in capital and some letters which are represented in small letters. This is because if the amplitude of the recorded wave is small, then it will be denoted by a smaller alphabet, and if the amplitude is considered to be significantly more, it will be denoted by a capital alphabet. And you can see here some alphabets, they are mentioned as R prime. And what you mean by that is, if you have a second waveform or second positive deflection, then you use the letter prime to differentiate between the 2 waves. So, now coming to the Q waves. So, Q waves, they are produced by the activation of interventricular septum, which are produced by the septal branches of the left bundle branch. And the current to this septum flows from left to the right direction. Normally, the Q waves are absent in many leads and it is present in the left-sided leads V4 to V6. So, the appearance of QRS complexes or the morphology, as I said, it varies in all your lead systems. So, now we will see what is the morphology of QRS complex in the chest leads. So, for this you must remember 2 points. The first point is the 2 phases of ventricular depolarization, and second one is the nomenclature of QRS complexes. If you understand these 2 points, then you can interpret the morphology of QRS complex in all the lead systems. So, first we will see the morphology of QRS complex in the chest leads. So, you have the right-sided chest leads which are V1 and V2 and the left-sided chest leads which are V4 to V6. So, the first phase of ventricular depolarization happens with the interseptum, that is your septal depolarization, and the direction of this wave is from left towards the right. So, what happens with V1? As the direction of depolarization is towards the right, you have a positive deflection, and as per the nomenclature of QRS complex, the first positive deflection will be labeled as R wave. As it is of lower amplitude, you are using a smaller alphabet to denote the R wave. So, what happens in the lead B6, which is oriented to the left side? As the depolarization wave moves away from it, you have a negative deflection. And according to the nomenclature, the initial deflection of or the first negative deflection will be labeled as Q. So, this R wave in V1 and Q wave in V6 They are called as septal R wave and septal Q waves because they are produced by the septal depolarization. So, the second phase of ventricular depolarization is with the ventricular mass, and as I told you, both right and left ventricle, they get stimulated simultaneously, but your left ventricle is electrically predominant over your right ventricle, and hence the wave of depolarization will be directed towards the left. So, now what happens in the right sided chest lead V1? As the second phase of depolarization wave moves away from it, you have a negative deflection which will be labeled as S wave because it follows the R wave. And in the left sided chest lead V6, as you have the depolarization wave moving towards it, you have a positive deflection which is labeled as R wave. So, this is the morphology of QRS complex in the chest leads. So, remember it is RS in V1 and in V6 it is QR. So, what you can interpret from this? Normally, here the R is denoted as small r because the amplitude is less. But in V6 it is denoted by a capital R because the amplitude is more, which means that as you move from V1 to V6, the amplitude of R wave increases progressively, whereas the amplitude of S wave decreases progressively. This is a point which you must keep in mind. So, in leads V1 and V2, your R waves represent your right ventricular activity and S waves represent your left ventricular activity. Whereas, in the left-sided chest leads V5 to V6, it is the vice versa. The R waves represent your left ventricular activity and S waves represent your right ventricular activity. And as I told you, you have a progressive increase in the amplitude of R wave as you proceed from right towards the left. This is what we call it as R wave progression. And at a certain point, say for example, either in lead V3 or V4, there will be a point where the ratio of R wave to S wave will be equal to 1. Or in other words, the amplitude of R wave will be equal to the amplitude of S wave. So, this transition where R is equal to S is called as a transition zone, and this may happen with either lead V3 or lead V4. And there are some pathological conditions where the transition may occur at a earlier lead or the later leads. So, if it occurs before V3, that is with either V1 or V2, we call it as early transition zone. And if the transition zone happens with leads V5 or V6, we call it as delayed transition zone. So, what is the importance of this R wave progression? So, it helps us to identify the normal and abnormal ECG patterns. So, you will not have a normal R wave progression with ventricular hypertrophy. It can be either a right ventricular hypertrophy or left ventricular hypertrophy, as well as in cases of myocardial ischemia where you have a loss of myocardium. And here again you have a loss of normal R wave progression. So, next is the appearance of QRS in limb leads. So, you have limb leads which are labeled as lead 1, 2, 3 and augmented limb leads which are AVR, AVL and AVF. So, remember leads 2, 3 and AVF, they are oriented downwards, whereas the leads 1 and AVL, they are oriented horizontally. And as I told you, lead AVR, it is also oriented horizontally and to the right. The important feature of AVR is all the waveforms in AVR will be negative. So, you have a predominantly negative QRS complex in lead AVR. So, then what about the morphology of QRS complex in other limb leads? So, here the morphology, it depends upon the electrical position of the heart or the mean QRS axis. So, if the heart is going to be electrically horizontal or if the mean QRS axis is directed horizontally, then you have a predominantly positive QRS complex in the leads 1 and AVL, because these two lead systems are oriented horizontally. And if the heart is going to be electrically vertical, then you have a predominantly positive QRS complex in the inferior leads, that is namely lead 2, lead 3 and AVF. So, next coming to the T wave. So, T wave, it represents your ventricular repolarization. And the normal T wave, it has an asymmetrical shape and it peaks towards its end. And the duration of T wave is about 0.27 second and the amplitude is about 0.3 millivolt. And there are certain features which you must remember while appreciating T wave in the ECG. The first point is the T wave always follows the path of your mean QRS axis. And if the T wave is positive in any one lead, it should remain positive in the subsequent leads. Say for example, if the T wave is found to be positive in lead V2, then it must be positive in the subsequent leads from V3 to V6. And the third point is the amplitude of T wave should be at least 1/8 less than and not more than 2/3 of the R wave amplitude. And the next wave which can be recorded on ECG is the U wave, and this wave, it reflects the slow repolarization of papillary muscles. And the duration of U wave is normally about 0.08 second and the amplitude is about 0.2 millivolt, and this U wave is rarely seen in normal people. And you can have a prominent U wave in metabolic disturbances like hypokalemia. Having discussed about the various waveforms, now we are moving on to the intervals and segments. So, when you look at an ECG, you will not only have the waveforms, but you also have a flat line which are called as the isoelectric line. So, what do these flat lines or the isoelectric lines represent? So, these lines represent that there is no electrical activation of the heart. If you are not recording any electrical activation, you get a flat line. So, the intervals, it includes your waveforms as well as the flat lines or the isoelectric lines, whereas the segments, it includes only the isoelectric lines in the ECG tracing and it does not include the waveform. So, the important intervals will be your PR interval, QT interval and RR interval, and the important segments will be your ST segment and TP segment. So, the first interval will be your PR interval. So, this is measured from the beginning of P wave to the beginning of QRS complex, and this PR interval, it represents the time taken by the impulse to travel from the atria to the ventricles, and it also includes the AV nodal delay, which is normally about 0.01 second. And the normal duration of PR interval is about 0.12 to 0.20 seconds, and if it gets prolonged or if it is more than 0.20 second, it tells us that there is some contextual abnormality. And the next important interval is your QT interval, which is measured from the start of QRS complex to the end of T wave, which means that it includes both ventricular depolarization and ventricular repolarization. Or in other words, it indicates the total systolic time of ventricles. So, the normal duration of QT interval is 0.4 seconds. And the important point about this interval is the QT interval, it depends upon the heart rate. If heart rate increases, your QT interval decreases and vice versa. And the second important point is the QT interval has to be measured in the lead which shows the longest interval. And because of these two reasons, you have to have a formula which corrects the QT interval. And this we call it as corrected QT interval, which can be calculated by two mathematical formulas. One is the Bassett formula or the square root method, and the other one is Hodge's method. So, the Bassett formula tells us that the corrected QT interval can be calculated by dividing the measured QT interval with the square root of RR interval. And next one is with the help of Hodge's method, where you have to know the heart rate in beats per minute, and you should also calculate the QT interval and substitute in this formula. So, this QT interval, if it is going to be prolonged, so the normal corrected QT interval is less than 0.43 seconds for male and less than 0.44 seconds for female. If QT interval is prolonged, it signifies either ischemia, hypocalcemia or ventricular conduction defects. So, next is about the segment. So, as we have discussed, segments are only the isoelectric lines and it does not include any waveforms. So, this ST segment is usually measured from the end of QRS complex to the beginning of T wave. So, this ST segment should be in level with the subsequent TP segment. So, TP segment is calculated from the end of T wave to the beginning of P wave. And the important thing about ST segment is a normal deviation of less than 1 millimeter is acceptable. If the deviation of ST segment is more than 1 millimeter, it is considered to be pathological. So, coming to the next important aspect, which is the calculation of heart rate. So, heart rate calculation can be done by using two methods. One is the box counting method and another one is QRS counting method. So, when we say box counting method, you can count either the number of large boxes or the number of small boxes. So, for this you have to know that one large square, which is equal to 5 millimeter, is equal to 0.2 seconds, and one small square, which is of 1 millimeter, is equal to 0.04 seconds. So, normally you have to take the ECG recording and you have to take two consecutive QRS complexes and count the number of either the large boxes or the small boxes. So, you have two formulas. One is either you can divide 300 by the number of large boxes between two QRS complexes, or if you are going to count the number of small boxes, then the formula will be 1500 by number of small boxes between two QRS complexes. So, you can look at this diagram. You have two QRS complexes, two consecutive QRS complexes, and you have to count the large squares. So, the number of large squares will be 4. So, here you are having 1, 2, 3, 4 large squares. So, if you are going to substitute in this formula, it will be 300 divided by 4, which is normally equal to 75 per minute. That will be the heart rate. Similarly, you can count the number of small boxes between the two consecutive QRS complexes and substitute in the denominator, and then you can get the heart rate. So, these are the two methods which are employed by counting the large boxes and small boxes. And you also have a easy method to estimate the heart rate, for which you have to memorize these numbers 300, 150, 100, 75, 60 and 50, which means that if you have one large square between two QRS complex, the heart rate will be 300. If the number of large squares is 2, heart rate is 150. If the number of large squares is 3, heart rate is 100. Number of large squares is 4, heart rate is 75. Number of large squares is 5, heart rate is 60 and vice versa. And the next method is the QRS counting method, for which you have to obtain a ECG recording for either 6 seconds or 10 seconds. So, remember, one large square is equal to 0.2 seconds. So, if you want to obtain a recording for 1 second, you have to count 5 large squares. And if you want to have a recording for 6 seconds, then it must have 30 large squares. And for 10 seconds, it must have 50 large squares. So, if you are going to have a recording for 6 seconds, then you have to multiply it with 10. On the other hand, if you obtain a recording for 10 seconds, then you have to multiply it with 6 to get the heart rate. So, in this picture, this is a recording for 10 seconds, and now here you can calculate the number of QRS complexes. So, here you have 3, 6, 9, 11. So, you have 11 QRS complexes in a 10-second recording. So, you have to multiply it with 6 to get the heart rate, which is equal to 66 per minute. So, this is the QRS counting method. So, EP caliper is an online software which can be used to calculate the heart rate and QT interval. So, this is the EP caliper app. So, here you have the open option where you can open the ECG images which are in the folders, and you have a caliper button where you have 3 calipers. One is the time caliper, amplitude caliper and the angle caliper. So, if you want to calculate the intervals and heart rate, you have to use the time caliper. So, I will demonstrate how to calculate the heart rate. So, I am using this time caliper, and then you have a zoom button with which you can magnify the image. So, as we all know, the heart rate has to be calculated between 2 QRS complexes, that is the peak of R wave. So, adjust it accordingly, and now we have to use the calibration setup to set the calibration. So, the standard calibration will be for 1000 milliseconds. Now, press OK, and you have to calculate the rate. So, here again you have to adjust it. So, between 2 QRS complexes, and you get the heart rate. Clear? So, for measuring the QT interval, you have to give inputs on how many intervals we are going to measure for the QT interval. So, I am going to measure for 3 intervals and then adjust it for 3 intervals, that is 3 QRS complexes, and then press measure. So, you have the calculated QTC which is appearing on the screen. So, the normal QT is about 0.2 seconds and the corrected QT interval is about 0.17 seconds. And you can also calculate the mean rate. Again, you have to feed the number of intervals we are going to measure, and you have the mean rate which is appearing here, which is about 80 beats per minute. So, nowadays you are having online application with which you can find the heart rate, you can also calculate the QTC, etc. You have the P wave which is best seen in leads 2 and V1, and in V1 the morphology of P wave is biphasic, and in lead AVR all the waveforms will be negative. So, the P wave, the height and width of it should not be more than 2.5 millimeter. Next is PR interval, which denotes the time taken by the impulse to travel to the ventricles. Normally, it is about 0.12 to 0.20 seconds. And Q wave is caused by the septal depolarization, and the depth of Q wave should be 25% of the amplitude of R wave, and the width should not be more than 1 millimeter. And next is the R and S waves which are produced by the ventricular depolarization. So, the R waves, it progressively increases in amplitude from V1 to V6, whereas S wave, it decreases in amplitude from V1 to V6. And QRS complex, it should be at least 10 millimeter in chest leads and 5 millimeter in the limb leads. And ST segment, it is an isoelectric line and it should be at the same level as the subsequent TP segment or the PR segment, and a normal deviation of less than 1 millimeter is acceptable. And T wave, it should be at least 10% of the R wave in the same lead. And QT interval, which is measured in the precardial leads, and it also depends upon the heart rate, and hence you have to correct it by using the mathematical formulas. So, the corrected QT interval must be less than 0.42 seconds for male and less than 0.44 seconds for female. So, the take home messages will be: the ECG is a recording of only the electrical activity of the heart and not the mechanical activity. That is, the pumping or the contractile activity of the heart cannot be recorded with ECG. And the second point is, the ECG does not directly depict the abnormalities in cardiac structure. So, if a patient has mitral stenosis or ventricular septal defect, it cannot be made out with the ECG. Instead, it gives only the electrical waveforms that are altered by this structural deformity. And third one is, ECG does not record all the electrical activity of the heart. This is because your surface electrodes can pick up only the waveforms which have a significant amplitude. And these are my references. And I especially thank Elsevier Publications for granting me permission to use the images of Goldberger's clinical electrocardiography, and I also thank my institute for giving me this opportunity. Thank you, and I wish you all a happy learning.